Coming Home Well, a multi-channel network of podcasts geared towards educating, supporting, and advocating for the veteran and veteran caregiver communities. Listen on your favorite platform. New episodes every week. Search for your favorite podcast by name. Coming Home Well, Behind the Service, Beyond the Front Line, Be Crazy Well, and Peace After Combat. Or visit our website at cominghomewell.com. Until all are home and all are well.
All right, listeners, I'm Libby and glad to be here today because I'm one of those girls who likes to push the boundaries and talk about controversial topics. And today's episode is definitely an interesting one. We're glad to have Dr. Michael Mitifer. He's a psychiatrist who's assisted in the research using MDMA, which if you guys don't know what MDMA is, it's ecstasy, or on the street they call it Molly, for veterans in the treatment of PTSD. So thank you for joining us today. I'm so glad you're here, Michael.
Thank you. It's a pleasure.
Yeah. So first, before we got started, it is just fascinating, the research that you guys have been doing and that you're currently doing. I'm so interested in hearing so much about it because when I think of MDMA, I think of raves and parties and, but like that's the average person. That's what they think of when they think of ecstasy and not so much the treatment of PTSD. So it's interesting, the study that you do have going on here. And I was preparing for the interview. I guess my biggest question is, how safe is that? How safe is it?
Well, that's a very important question. And that was one of maybe the key question when we started our research, which has been over 20 years now that we've been working on these protocols. And the answer is, like any drug, MDMA has risks as well as potential benefits. And what we know is that in clinical settings with pure MDMA, the way we're using it, giving a few doses, that people only get MDMA a few times, usually 3 times a month apart. And that's after careful medical and psychological screening and monitoring. So we have a very good safety record in our clinical trials in that setting. So it doesn't mean that MDMA can't be dangerous. People have died, in fact. It's rare, but some people have died from dehydration and overheating, or sometimes brain swelling from too much hydration. So it has risks, certainly. And one of the main ones is it increases blood pressure and pulse quite a bit. So it's sort of like exercise. And we screen people to make sure they don't have some significant heart disease or vascular disease or something like that. So the answer is, in the right setting for properly screened people, it's a good risk-benefit ratio is what we're showing in our clinical trials.
Yeah. So can you share with our listeners a little bit about your background, your expertise, and what really inspired you to work with our military veterans?
Yeah. Well, I'm a physician, and I actually practiced emergency medicine for 10 years first. And then in 1991, I went back and did psychiatry residency, psychiatry training, and was very interested in post-traumatic stress disorder and PTSD, and interested in techniques for shifting consciousness to help people heal. But I thought that time that we had to do that with other experiential techniques like breath work. And so I practiced psychiatry, and my wife, Annie, is a nurse, and we did breath work groups together along with our clinical practice and treating people. And over time, we saw the promise of having some way of helping people kind of shift their perspective. But and holotropic breathwork actually was a way that was very effective for many people at doing that. But everything else in medicine, it didn't work for everybody. And so it became, in our view, it became kind of unethical that we had these reports from before MDMA and other psychedelics became illegal. There were published reports and some research with LSD and other drugs, and quite a few case reports with MDMA indicating that it seemed to be helpful for catalyzing psychotherapy. So it just seemed, after a while, all these people were suffering. It seemed like this is ridiculous that, drug companies are going out and finding new compounds to test for treating people, which is good. But here we have a compound that people have already reported, reputable psychiatrists and psychologists have reported could be helpful, and yet it was just dropped once it became illegal, and there was no research even going on about whether it could be, whether we could show whether it's safe and effective. So that's really, we didn't set out to be researchers. We were clinicians treating people with PTSD and other things, and we kind of were forced into research because of the clinical need. So that's how that's why we started seeing if we could pursue this. So that's kind of the background. And the idea being partly, again, it's different from most drug studies in that we're not just studying a drug. People don't take the drug every day and then see how they're doing. It's really the model is, the idea is, the hypothesis is that MDMA will catalyze therapy. In other words, it doesn't cause it. It's not the definitive treatment, but it's a way of helping people have effective therapy. And there are lots of ideas about why that works. Part of it certainly seems to be MDMA kind of helps decrease fear and defensiveness and help people talk about traumatic things in a way that they hadn't been able to before.
That's what I was going to say about the studies exactly. Do you want to go into the studies exactly, like how that works when you?
Sure, yeah. Well, we're basically, I say we, it's the MAPS Public Benefit Corporation. It's a nonprofit model for drug development. But even though it's a nonprofit and a public benefit corporation, we're going through the same process that any pharmaceutical company would do, because that's what you have to do to see if FDA will approve a drug for clinical use. So there are different phases. It starts with animal studies, which have already been done. And then some various people, including Charlie Grove, was the first one, the head of child psychiatry at UCLA. He did a phase 1 trial, the first one to start looking at safety in healthy volunteers. And then we started with phase 2, which is the next phase of drug development. If a drug appears safe enough in healthy volunteers, then the next phase of drug development is phase 2, where you test it in fairly small groups of people with a diagnosis to test the safety and the effectiveness for treatment. So that's where we started. Our first study actually started treating people in 2004, March of 2004. And so there's been a series of phase 2 trials. We've done a couple of those in Charleston, and then there have been others in Colorado and Vancouver and Israel and Switzerland. And so at the end of 2017, after those years of the phase 2 trials, then FDA gave permission to go into phase 3, which is the final phase before you can apply for a drug to be approved. So now for the last several years, we've been conducting phase 3 trials in 14 sites across the U.S., Canada, and Israel. And we finished the first phase 3 trial with 90 people and published that last year. It was very successful, a good safety record and very strong treatment effects. So now we're a little over halfway through the second phase 3 trial. So we hope that by the end of this year, 2022, we will have finished that and be able to submit an application to the FDA to see if MDMA can be approved for clinical use for treating PTSD. So that's what we've been doing.
So what you talked earlier about, it allows the veteran to open up while they're using the MDMA. So what is that process? So they take the ecstasy or the MDMA, and then what happens? What's the process like?
Yeah. An important part of the process happens before that, as I say, informed consent, really careful information and consent, and then medical and psychological screening. And then they need to have a certain level of PTSD symptoms to qualify on what's called the CAPS, the Clinician Administered PTSD scale. Is kind of like the gold standard for measuring PTSD symptoms. You're probably familiar with that. I'm sure you are. So if they meet the criteria and don't have any medical problems that might be a safety concern, then we start with preparation sessions. So they have 3 90-minute sessions with 2 therapists. This is all with 2 therapists, with a chance to get to know the therapist and for them to get to know the person and to prepare people for what this might be like and what the approach to the therapy is. So that preparation is really important. And then on the day of the session, people come to the office about 9:30 and talk with the therapist, have a drug screen and a urine pregnancy test if they're possible to get pregnant. And then they're offered the capsule around 10 a.m. And depending on the study, that it's either MDMA or placebo. Or in some studies, it's a low dose of MDMA to be like a placebo. So a kind of active comparator. So they're all controlled, randomized, blinded. Nobody knows what people are going to get. So they get the capsule. And then a lot of it is that they're encouraged by the therapist to basically they're sitting on a sofa or futon. So they can either sit up or lie down if they want. And the therapists are in chairs near them. And they're encouraged to, after a while, to close their eyes and focus inward with eye shades and headphones if they're comfortable listening to music, but that's optional. And then the approach to the therapy is that the therapists aren't trying to direct what happens. They're trying to support what comes up for the person, because we have this hypothesis that we basically learned from others. Stanislav Grof was one of the early LSD researchers, a psychiatrist. He talked a lot about this idea of there's this inner healing capacity that individuals have. And if you can help them access that, then that's a better guide to what experience they need than some idea that the therapists have ahead of time. So it's very centered on the respecting the person's healing capacity. And then the therapists are there to support and help with that. Sometimes some direction can be really helpful, but the idea is it's more out of respect for knowing that the person's own inner healing intelligence, if you will, brings up is the most useful one. So, and then the therapists check in every hour to talk to them, and they can talk to the therapist anytime they want. So it usually develops into kind of a rhythm of some periods of talking to the therapist, and then the therapist might say, well, maybe this would be a good time to focus back inside and see what else you might discover and come out and talk to us whenever you want. So it really varies. Some people will immediately start talking about the trauma. Other people might have a different experience first, something about childhood, or if it's war trauma, things about relationship and childhood come up also. And we never know what order things are going to come up. But what we find is people very often seem to, be able to face difficult things in a way that they hadn't been before and kind of have a new perspective about things. It doesn't mean it's just easy by any means. You mentioned raves in the beginning. We had several people in our study say, I don't know why they call this ecstasy. I don't know how people could dance taking this. Some people said that. But the idea is that if your focus is on healing and you have severe PTSD, you're very likely to have some painful things come up. And processing trauma is painful with or without MDMA. It just means that what we find is so often MDMA makes it possible. It's not a cakewalk, and people are still connected to the emotions, but they have a sense. Sometimes people tell us, I can remember, like I'm thinking of a veteran describing when his truck was blown up and he was injured and his friend was killed, saying, I've never been able to remember it so clearly before and feel what it was like so clearly, but I'm able to do it without being overwhelmed. So it seems to be, we have a lot more to understand about how it works. That's true of all psychiatric medicines, basically.
Right.
But it seems that's part of it. It has that quality of allowing people to approach difficult things with less defensiveness and more clarity.
Yeah.
It's most drugs that decrease anxiety also tend to make you drowsy or interfere with memory. MDMA seems to kind of decrease anxiety in a certain way, but without depressing their consciousness. They're actually often more alert and have better memory sometimes.
Mm-hmm. So you said the studies are controlled in the controlled environment with the therapist, which I think is wonderful. How do you have control groups, and how do you give, because that was my confusion about it, is how do you have control groups with a placebo, wouldn't they be able to tell if they're taking a psychedelic or not? I mean,
that is one of the biggest challenges of this research design, really. And we actually had the National Institute of Health organized a workshop a few weeks ago that I spoke at, and lots of people spoke about, this whole issue. How do you study these things?
Yeah.
One of my talk was about what we've learned about that challenge of the blind, because what we found was, yes, usually people are able to guess correctly. Not always. Sometimes they're wrong. But so our first study was with an inactive placebo compared to MDMA. And it was quite easy to tell most of the time. So we did a series of studies using lower doses of MDMA as an active comparator to see if it could fool us and improve the blinding. And what we found was it did improve the blinding somewhat, but it caused another problem, which was that it interfered with the therapy. People got more anxious, but it didn't help them. So because one thing about these studies is we've had significant improvements with the therapy alone. Even in people who have failed other treatment with therapy and medicines, it's a lot of therapy. 8-hour sessions can be very powerful, even without MDMA. So what we see is significant improvements with just the therapy with placebo, much bigger with the therapy plus MDMA. But then what we saw when we added the low-dose MDMA as a comparator, even though the blinding got somewhat better, the therapy only worked half as well. So it didn't really work to be comparing your treatment to something that interferes with your treatment.
Right.
So, and then other people have done studies trying to just see about blinding with MDMA using methamphetamine, or methylphenidate or methamphetamine. I think, forgotten the details, but everything else that was tried also had its confounding effects. The amphetamines actually improved sociability, kind of a similar way that MDMA did. So we haven't been able to find anything that improved the blinding without having a problem like that. So the FDA agreed, detailed discussions with them about designing the phase 3 trials. And they agreed, it's the only way to do this really is to do the best we can with the blinding, but then we have independent raters that are remote, that are really well blinded, that never rate the same person twice. They don't know where the same person didn't study. So it doesn't solve the problem of the therapists and the participants usually being able to guess.
Mm-hmm.
It's basically that was the best we could do, and the FDA agreed that was adequate.
Yeah,
because it's a challenge. Therapy studies can't really be blinded. People know they're getting therapy, and this is really a therapy study along with the MDMA. So it challenges. We were saying in that meeting with the NIH a couple of weeks ago, it's a challenge to figure out how do we need to adjust the way we do clinical trials in order to test these effectively, because we can't just ignore this powerful effect we're seeing just because it's hard to blind with these compounds. So I think we're being successful in that way. And I think there are a lot of other things that make you feel better, make me at least feel better about the fact that the blinding is hard to maintain, which are several features that suggest that it's more than a placebo effect, such as we see most people have sustained results a year or more later. In one follow-up study, we had 3.5 years later. Most people, not everybody, some people did relapse, but most people were doing actually at least as well as they had been doing 2 months after the last treatment. So that implies something important. We've seen changes in personality measures, increased openness and decreased neuroticism. That doesn't really sound much like a placebo effect. And then the other thing is people so often have a coherent story, a narrative of what happened for them and why they're feeling better. because they were able to process this in a new way, or they were able to see a more accurate perspective about things. So it's not just, I took a pill and I felt better. So it's that it seems like a meaningful process. And then the other thing is, in our first phase 3 study, we measured a number of secondary measures about things like self-judgment, self-compassion, connection with feelings, self-efficacy. And we saw big improvements in those areas, along with the improvements in PTSD symptoms. So if you take the big picture, it's kind of reassuring more than just if it was a pill and then, you couldn't blind very well.
Yeah, that's what I was wondering, what the long-term effects of the benefits of the therapy have been for the veterans that were participating in that research.
Yeah, well, that's one of the really encouraging things about it is, on average, when we look at the phase 2 trials, we don't have long-term follow-up on phase 3 yet. But when we did the longer-term follow-up in phase 2, consistently, on average, people were doing better at 1 year than they were at 2 months. So that's not about the drug's been out of their system for a long time. So that is consistent with our hypothesis that what this does is catalyze a therapeutic process. And that therapeutic process keeps unfolding. People see things differently. They have a different relationship to their emotions, and they take that into their life, and things continue to improve for a lot of people. So that's a very encouraging news, and it'll be good to see what the long-term follow-up for the phase 3 is.
Yeah, absolutely. Now, have you found that that the research I'll say veterans, I don't want to say that sounds so sterile, research participants, but the veterans that participated in that study, did you find that in the follow-ups that they were participating more in like counseling, therapy sessions, things like that? What's kind of like the follow-up afterwards, after the study's over with?
Yeah, that's a really good question. What we did are long-term follow-up questionnaires, and what we found was a lot of people, we've studied that one of our phase 2 studies was just veterans and first responders, mostly veterans who had served in Iraq or Afghanistan, and some veterans with military sexual trauma. And then the first study we did was with people with crime-related PTSD. So we have data from both. But the veterans, what we find is, there was a requirement that they all had to have had treatment before. And a lot of them had medicines and therapy, but some had not had therapy in veterans. Some had just had medicines. But they'd all received treatment through the VA without success, or still had significant symptoms. So what we noticed was most people didn't go back into therapy, but it was interesting. There were a couple of veterans two people I can think of, who said they had been offered therapy at the VA. And in both cases, I think it was cognitive processing therapy. And they both said, one of them said, he didn't see the point. And the other one tried it, but it was too trigger. And maybe he tried prolonged exposure too. I don't remember. Anyway, it was interesting. At the end, neither of them had PTSD anymore. But that both of these veterans said, now I see the value of therapy, of working with your inner process. And even though my PTSD is basically gone, I think I'm going to take my VA therapist up on doing some of that cognitive processing therapy, because I see the value of kind of having therapists help you look at things. So
that's a great benefit to it. Absolutely. Sure.
I think so.
Yeah, absolutely. So you follow up. So we've established that you guys do follow up afterwards, like a longitudinal study afterwards. How are you guys ensuring that they aren't experiencing either abuse of this same drug afterwards? Because MDMA is highly addictive. So how are you guys ensuring that they're not experiencing some type of addictive behavior to that drug or some other type of substance afterwards? Is there some type of follow-up with that?
Yeah, we track that. I wouldn't agree that MDMA is highly addictive.
Is it Is it a type of methamphetamine or no?
It's related. It's a type of amphetamine. But I don't want to imply that it can't be. It's never misused. And So it can be psychologically addictive in a way. And certainly people can get into problematic patterns of use. But the studies rating addictiveness, it's not nearly as addictive as, say, methamphetamine or opiates. So it's similar on that scale, not at the top. But anyway, it's an important question. And so we track that. We have a letter from the government assuring people they wouldn't be prosecuted for admitting to illegal drug use. So we've had very few people say that they took it again afterwards. A few people have. I'm not sure if I know the latest data, but I think all the ones that took it afterwards have taken it before. Most people, I think about 60% have never taken it before, and they couldn't have been heavy users, but a certain number of people had tried ecstasy before. The one person who tried it afterwards who hadn't tried it before, it was when we only had 2 sessions in the first study, and this person went home and she told us afterwards she asked a friend to sit for her, and she got some ecstasy and tried to recreate the therapeutic session setting, but she said it wasn't satisfactory. She'd never do it again. So overall, it seems that people tend to, if they're introduced to it in this kind of clinical setting as a treatment where we're monitoring their blood pressure and they feel a lot of safety in that way, most of them they're inclined to think of it as a treatment, not something that they would do otherwise. So it doesn't seem to be a problem. I'm sure it's not zero, the number of people that would go out and use it again, but we haven't seen a problematic situation in that way. One thing about MDMA that's different from a lot of the more addictive things is it stops working if you take it too often.
Okay.
So even though people get into, I think, some really problematic use patterns where they take it too often and too much, that tends to peter out after a year or so, just because it's not working anymore. So it doesn't mean it's not a problem to pay attention to, but it doesn't seem to be a big problem.
Mm-hmm.
And, what we picture, we don't know for sure, but what we think is going to be, if it is approved, if our current study is successful and it's approved, it won't be a take-home drug. It'll be shipped directly from the manufacturer to the clinic. It'll have to be a licensed clinic that has, meaning just that the people have had proper training and they're set up to store it safely and to receive it from the manufacturer. So it's not going to be really possible to have people divert it.
That was my next question is if it is approved through the FDA after the third trial, would it be available as a prescription use for PTSD treatment, say that you take other PTSD drugs for, right? But it is only going to be for clinical setting use in relationship with a therapist. Is that
right?
What understanding?
That's what we believe. I'm pretty sure that's true. You never know for sure until the FDA decides, but we think there will be it's called a REMS, a risk management, risk evaluation and mitigation strategy. So I think they'll require something like that. And we think that's a good idea.
If I can put my 2 cents into the research at all, I think that's great. I think that would be a great way to do that for sure, to mitigate any type of risk that way. Because my fear is, and I hate to speak through fear, my fear is we get into another opioid crisis with this medication. So that's why I asked that specific question, because I don't want to get into, we have enough addiction and issues in the United States, and around the world, really. And
yeah.
Just trying to avoid those altogether, and thinking about that during the research process is avoiding that type of.
Yeah. Because even though MDMA seems to have some really positive qualities and be helpful to people so often, it's not a trivial experience.
Right.
Without proper preparation and then integration, people can get into trouble. This stirs things up. Sometimes people talk about stuff for the first time and afterwards they have second thoughts about whether that was okay. And we've had some people get despondent about that. And if you have proper preparation and then support afterwards, that can turn into part of the healing process.
Sure.
But if people just didn't know that and didn't have supported preparation and took it, they could get into trouble.
Yeah. Yeah. So what are the next steps then in your research? What are your next steps going forward?
Yeah. Well, the next thing is to finish this second phase 3 trial in the U.S. But meanwhile, we're already starting phase 2 trials in Europe, and we've got them going on in several countries already, and with a few more countries coming online soon. So the next step will be hopefully approval in Europe is what we're hoping for. And Israel is already Israel and Canada and the U.S. are kind of part of this first wave to hope for approval if this study is successful, and then moving into Europe, but also other parts of the world. We've already had a study in Brazil. It wasn't a sponsored study, but it was someone trained by MAPS with MAPS MDMA. So it's spreading geographically. And then we also have a section now that I'm involved with where other investigators who want to study other things can apply to use the MAPS MDMA if they get a protocol approved by the FDA and DEA. So people are starting to look at other possible indications like eating disorders or other things like that, depression, lots of things to be researched. So
absolutely.
Finding out what else it might be useful for.
Yeah.
And then a big part of our efforts now is training therapists and then supervising them when they're working. Now they have to work on clinical trials, so that's a big challenge. Is if we do get approval in a few years, we think there's going to be a lot of demand, and we don't want to be caught flat-footed where here we got an approved treatment and people need it. So we're trying to get ahead of the curve with that. So that's one of our challenges. We've trained quite a few, more than 1,000 therapists, but how do we keep doing that and how do we expand that and still maintain the quality that we think is important? So that's another big part of the effort now.
That's really smart. You're thinking ahead of time on all of that. So that's really smart research thinking there. Because is that the trial then that you guys did? I seen a trial that you were working with clinicians that worked on this research. So is that the research that you did then? Was you're training clinicians then to work with the research participants for this? Is that because I think there was 3 that you worked on. Is that correct?
Trials?
Mm-hmm.
Yeah, more than 3, but yeah, maybe you're referring to, the first one was called MT1, MAPS Training Protocol 1, where we got permission to give MDMA to therapists that had been through our training. Is that?
Yeah, that's the one I think I'm Now, do you actually give the drug to the therapist?
Yes.
So they actually experience the same thing that the participants would experience.
Right. In the same setting. So, yeah, we've been doing that for a number of years because we think it's not required. We would never want to require somebody to take a drug, and some therapists might have a contraindication. But we think in general, it can be very helpful for the therapist to have experienced it at least once themselves. Because part of the challenge for the therapist is to realize how much can be going on that they're not doing this, that they're not, and they might not even know what's going on at a certain moment, but it's important if the person is having a deep process, not to have to interrupt it all the time for them to explain it to you at the moment. So it helps therapists, if they've had their own experience, to trust that is the case. So, that first study, we got permission for 20, and then we got permission for 100, and then we expanded to 130. So we're pretty much at the end of that. But now we have permission for another similar trial to be able to continue to give that experience to therapists. That trial isn't going at the moment just because we're not just hiring the staff to get that new study going. But we think that is important when it's possible.
I think all of this is so fascinating. It's just so interesting. And I appreciate what you're doing to help our military families and our veterans to be well. So thank you for being here. Did you want to add anything else that we haven't maybe covered?
Well, I'll just say it's been a real honor and pleasure for us to be able to work with the veterans in that study. I'd worked with some veterans in my residency, I worked at the VA, of course, but I hadn't worked with that many veterans until we started doing that study. And it was just a very rewarding and heartwarming experience. It was an amazing group of people that volunteered for this. And we always feel like it's a privilege to be able to participate in somebody's deep healing process, especially if they've been suffering for years and you see that they can have a real shift, and with their families too. We did a small study with couples where we were able to give both people MDMA at the same time. And one of those was a veteran actually from Bosnia. Most were not veterans in that study, but in the study with mostly veterans, we always engaged their partners, spouses, partners, if it was appropriate, if we could. And some really beautiful things happened just to see. We got to know people's spouses too. And I got to say, we really wish we could have had another couple study so the partners could have their own experience. It was so powerful for them in the couple study that they could have that experience together. And so I'm hoping that there'll be more of that. We're actually, Chris Stauffer, a psychiatrist in Portland, is good. We're working with him on a protocol to do group therapy in the VA. So I'm hoping, and of course, there's a study, there are studies in 2 VAs that are starting right now. So I'm hopeful that as we go on, we'll have more group and couples studies and eventually therapy, because you see how I don't have to tell you that both people in a partnership are involved when one person has PTSD.
Yeah.
For sure.
Absolutely.
So it makes sense. We worked in the couple study, we did that with Candace Monson and Ann Wagner. And Candace is a psychologist now. We're both psychologists in Toronto. But Candace developed this method, and she had been the head of women's mental health at the Boston VA. So she realized her model is that the couple is the patient. And that was how we were able to convince the FDA. That's why we need to give both people MDMA at the same time. And they understood that because of Candace's data without MDMA, but using that method of cognitive behavioral and joint therapy. So I think it's going to be exciting to see how it unfolds if things keep going well.
Yeah. I love it. All good stuff. Keep doing what you're doing. I appreciate you. Thank you for being here today. And listeners, thanks for joining us as we educate, support, and advocate for our veterans and their caregivers. And we'll talk to you next week.